This year in ESMO 2022, we have had 3 very nice neoadjuvant trials exploring different combination strategies using immunotherapy with Nivolumab in the neoadjuvant setting in patients with early-stage resectable non-small cell lung cancer. The first one is NEOpredict-Lung trial, which explored combination of Nivolumab plus relatlimab and anti-LAG-3. The second one is the INCREASE trial, which explored the combination of Nivolumab, Ipilimumab with the standard chemotherapy and radiotherapy in tumors that are T3 and T4 of doubtful resectability. And the third and last study is the sub-analysis, exploratory analysis of the CheckMate 816 trial, which is phase 3, exploring the combination of Nivolumab and chemotherapy versus chemotherapy. The NEOpredict study is a small study, phase 2 study, in which they tried to evaluate which was the role of combining Nivolumab plus an anti-LAG-3 inhibitor, which is called relatlimab. So the main point of the study was to see if the combination allows the feasibility for surgery after neoadjuvant setting. They included few patients per arm, so there were 30 patients treated with neoadjuvant Nivolumab and 30 patients treated with neoadjuvant relatlimab plus Nivolumab. The primary endpoint was met because the feasibility for surgery was the same for both arms, 100%. And the complete pathological responses were quite similar between both arms. They were 27% and 30%. So my take-home message could be the combination seems feasible, it's well tolerated. However, I'm not sure that the pathological complete responses seem to be increased that much. And I wonder whether adding chemotherapy to the double Nivolumab and relatlimab could improve further the pathological response, complete responses. In ESMO 2020 has been presented the results of the INCREASE trial. The INCREASE trial is a very interesting trial because it represents like a new step forward the treatment with immunotherapy in locally advanced non-small cell lung cancer. So what authors did was to evaluate in tumors T3 and T4, that is pancreas tumor that have ingrowth to the surrounding tissues. So what they did is to evaluate if adding Nivolumab and Ipilimumab to the standard of care radiotherapy and chemotherapy could improve complete pathological responses as well as to enhance the T-cell response. And it's very nice because the primary endpoint was met, so the authors aim to improve more than 30% the pathological responses that you can see with chemotherapy and radiotherapy, and indeed they get 63% of pathological complete responses and 79% of major pathological responses. And nicely, they also demonstrate that when they got these tumors and the lymph nodes after surgery, they demonstrate that the combination of Nivolumab, Ipilimumab plus chemo and radiotherapy indeed increased the T-cell response. So I could give 3 takeaway messages about the INCREASE trial. The first one, and this is a very preliminary study, very few patients included 26, we need reproducibility. My second takeaway, I would like to have more data on the outcomes, surgical outcomes of these patients because those are heavy, extended surgeries. And my third takeaway, overall survival, long-term outcomes, we need to confirm that this 4-modality treatment improve outcomes compared to others such as the Pacific trial. In ESMO 2022, they presented the results of an exploratory analysis of the study CheckMate 816. This is a phase 3 trial neoadjuvant study which compared chemotherapy plus Nivolumab versus chemotherapy in patients with resectable stage 1B, 3A, non-small cell lung cancer. So in this exploratory analysis, the authors aimed to evaluate which was the benefit and the pathological benefit or pathological features of those patients in the study with lymph node involvement. What they observed is that both patients with lymph node involvement and those patients without lymph node involvement derived the same benefit from the treatment with chemotherapy and Nivolumab. And on the other hand, they observed that those patients that had complete pathological responses both in tumor and in the lymph nodes were the ones that derived the highest event-free survival rate. So my takeaway could be that downstaging in the mediastinum is very important when you are doing neoadjuvant strategies, mainly in those patients that have N2 disease. And this is very important, and it's our clinical practice. So I really would like to know which is the prognostics and the event-free survival for those patients that in the CheckMate 816 trial, comparing those patients that achieve complete response in the N2 mediastinum disease and those patients that did not achieve response, because that can change our current standards of care.